Understanding Normal and Pathological Gait. Mahmood Saminai, MD. Assistant Professor LSU PM&R. Objectives, basis for DX and RX of pathological gait. Rational prescription of orthotic devices. Understanding and correction of prosthetic ambulation. Gait cycle, definitions. Normal gait equals series of rhythmical, alternating movements of the trunk on limbs which result in the forward progression of the center of gravity. Series of controlled falls. Gait cycle, definitions. Single sequence of functions by one limb. Begins when reference foot contacts the ground. Ends with subsequent floor contact of the same foot. Gait cycle, definitions. Step length equals distance between corresponding successive points of heel contact of the opposite feet. Right step length equals lieutenant step length, in normal gait. Gait cycle, definitions. Stride length equals distance between successive points of heel contact of the same foot. Double the step length, in normal gait. Gait cycle, definitions. Walking base equals side-to-side distance between the line of the 2 feet. Also known as stride width. Gait cycle, definitions. Cadence equals number of steps per unit time. Normal, 100 to 115 steps per minute. Cultural/social variations. Gait cycle, definitions. Velocity equals distance covered by the body in unit time. Usually measured in meter per second. Instantaneous velocity varies during the gait cycle. Average velocity, m per minute, equals step length, m, x cadence, steps per minute. Comfortable walking speed, CWS, equals least energy consumption per unit distance. Average equals 80 meters per minute, tilde 5 kilometers per hour, 3 miles per hour. Gait cycle, components. Phases. Stance phase, 2, swing phase. Reference limb. In contact not in contact. With the floor. Gait cycle, components. Support. 1. Single support, only one foot in contact with the floor. 2. Double support, both feet in contact with floor. Gait cycle, subdivisions. Eye stance phase. 1. Heel contact, initial contact. 2. Foot flat, loading response, initial contact of forefoot W. Ground. 3. Midstance, greater trochanter in alignment W. Vertical bisector of foot. 4. Heel off, terminal stance. 5. Toe off, pre-swing. Gait cycle, subdivisions. B swing phase. 1. Acceleration, initial swing. 2. Mid-swing, swinging limb overtakes the limb in stance. 3. Deceleration, terminal swing, gait cycle. Time frame. Eye stance versus swing. Stance phase equals 60% of gait cycle. Swing phase equals 40%. B single versus double support. Single support equals 40% of gait cycle. Double support equals 20%. With increasing walking speeds. Stance phase decreases. Swing phase increases. Double support decreases. Running. By definition, walking without double support. Ratio stance/swing reverses. Double support disappears. Double swing develops. Path of center of gravity. Center of gravity, CG. Midway between the hips. Fusum front of S2. Least energy consumption if CG travels in straight line. CG. Path of center of gravity. A. Vertical displacement. Rhythmic up and down movement. Highest point, midstance. Lowest point, double support. Average displacement, 5 centimeters. Path, extremely smooth sinusoidal curve. Path of center of gravity. B. Lateral displacement. Rhythmic side-to-side movement. Lateral limit, midstance. Average displacement, 5 centimeters. Path, extremely smooth sinusoidal curve. Path of center of gravity. C. Overall displacement. Sum of vertical and horizontal displacement. Figure 8 movement of CG as seen from AP view. Horizontal. Plane. Vertical. Plane. Determinants of gait. 6 optimizations used to minimize excursion of CG in vertical and horizontal planes. Reduce significantly energy consumption of ambulation. Classic papers, Sanders, Inman, 1953. Determinants of gait. 1. Pelvic rotation. Forward rotation of the pelvis in the horizontal plane approximately 8 on the swing phase side. Reduces the angle of hip flexion and extension. Enables a slightly longer step length without further lowering of CG. Determinants of gait. 2. Pelvic tilt. 5. Dip of the swinging side, i.e. hip adduction. In standing, this dip is a positive Trendelenburg sign. Reduces the height of the apex of the curve of CG. Determinants of gait. 3. Knee flexion in stance phase. Approximately 20 dip. Shortens the leg in the middle of stance phase. Reduces the height of the apex of the curve of CG. Determinants of gait. 4. Ankle mechanism. Lengthens the leg at heel contact. Smoothens the curve of CG. Reduces the lowering of CG. Determinants of gait. 5. Foot mechanism. Lengthens the leg at toe off as ankle moves from dorsiflexion to plantar flexion. Smoothens the curve of CG. Reduces the lowering of CG. Determinants of gait. 6. Lateral displacement of body. The normally narrow width of the walking bus minimizes the lateral displacement of CG. Reduced muscular energy consumption due to reduced lateral acceleration and deceleration. Gait analysis. Forces. Forces which have the most significant influence are due to 1. Gravity. 2. Muscular contraction. 3. Inertia. 4. Flow reaction. Gait analysis. Forces. The force that the foot exerts on the floor due to gravity and inertia is opposed by the ground reaction force. Ground reaction force, RF, may be resolved into horizontal, HF, and vertical, VF, components. Understanding joint position and RF leads to understanding of muscle activity during gait. Gait analysis. At initial heel contact, heel transient. At heel contact. Ankle, DF. Knee, quad. Hip, glut. Max and hamstrings, gait. HC. Initial HC. Heel transient. Foot flat. Mid stance. Gait. HC. Initial HC. Heel transient. Heel off. Toe off, gait. Low muscular demand. 20 to 25% max. Muscle strength. MMT of 3+. Common gait abnormalities. Antalgic gait. Lateral trunk bending. Functional leg length discrepancy. Increased walking bus. Inadequate dorsiflexion control. Excessive knee extension. Don't walk behind me, I may not lead. Don't walk ahead of me, I may not follow. Walk next to me and be my friend. Albert Camus. Common gait abnormalities. Antalgic gait. Gait pattern in which stance phase on affected side is shortened. Corresponding increase in stance on unaffected side. Common causes: OA, FX, tendinitis. Common gait abnormalities: bilateral trunk bending, Trendelenburg gait, usually unilateral. Bilateral equals waddling gait. Common causes: A. Painful hip. B. Hip abductor weakness. C. Leg length discrepancy. D. Abnormal hip joint. X. 2. Hip abductor load and hip joint reaction force. X. 2. Hip abductor load and hip joint reaction force. Common gait abnormalities: C. Functional leg length discrepancy. Swing leg, longer than stance leg. 4 common compensations: I. Circumduction. B. Hip hiking. C. Steppage. D. Vaulting. Common gait abnormalities: D. Increased walking verse. Normal walking verse, 5 to 10 centimeters. Common causes: deformities, abducted hip, valgus knee, instability, cerebellar ataxia, proprioception deficits. Common gait abnormalities: E. Inadequate dorsiflexion control. In stance phase, heel contact, foot flat, foot slap. In swing phase, mid-swing, toe drag. Causes: weak tibialis and spastic plantar flexors.